Well, I want to thank y'all for letting us take a little of y'all time to come talk about hospice, because it's something that's probably about what we run across. About 80% of the people that think they know about hospice, it's incorrect, and they kind of have some of the old things that they only think hospice was for cancer patients and patients that were going to possibly live maybe a week or so, and that's totally opposite of what the new. I like to tell everybody, let me talk to you about the new hospice, and it kind of opens people's ears up to listen to what we have to say. Our hospice has been in our area, in the Mamou area, for over 25 years. So we're one of the oldest hospices around this area. We're the closest hospice that's officed to Eunice. I'm sure y'all serviced by some of the other Lafayette offices, but we're in Mamou. We have nurses in this area, and of course we have physicians in this area. We have one of y'all local physicians, Juliet Robinson, is one of our medical directors. Brent Ardeman, which actually works out of Mamou but actually lives in the Eunice area, is one of our medical directors. So we are in the area, and we would like to serve the people in the local area. One thing that I like to tell people about hospice is you do have choice. When you do come to that point where you are going to be choosing a provider, everybody has a choice to choose whichever. If you have a provider letter that's showing all the different hospices that you can choose from, you can pick whichever one you want. So remember that whenever it comes down to that, if you need to use our services. And I'm going to let Ms. Rose kind of go through some of the different qualifications that for the patients that do meet the criteria for hospice. It's not only a cancer patient, and she'll go in and talk to you about that. Thank you.
Thank you, Paul. Again, I'd like to express our gratitude for allowing us to come and be part of your little, I guess y'all meet monthly, Leslie?
Weekly.
Weekly, wow.
On Thursdays.
Y'all do a fantastic job. Hospice, as a lot of people know, when you hear the word, people tend to kind of shudder. It doesn't matter what hospice it is. It has changed over the years. Medicare and Medicaid has opened the door, allowed us to provide more and more services. You do have to meet qualifications, and that is basically the physician states in their best opinion. You have 6 months or less, but if a patient is still living after 6 months, if they still qualify, they go through a recertification process, and if they still meeting criteria, it doesn't mean that we just drop them. We continue with them. We have some patients that we do not give up on our patients. We believe in a lot of preventative care. It's supposed to be non-aggressive treatment, but we work at making each day of their life as comfortable as possible and let them go through this journey the way they want to go through it. We review every patient, see if we're lacking in anything we need to provide to these patients, and we work on those processes and keep the physicians notified. We do allow the patient to keep their physician. They've gotten very close to these physicians, and the physician is very interested in their care. So we do send them a report every 2 weeks to let them know the progress, or in some sad cases, the decline of the patient. But we do keep them abreast and involved in the patient care. Does anybody have any questions? We know when we get out there, we still hear, the old myths that people think about hospice. They think it is for patients at the very end of life. And we're trying to be in the community as much as possible and try to, get people to understand that the sooner we get patients, the better it can be for them.
It goes through their personal doctor. People don't just go to call y'all.
No, you have to be referred by a physician. Now, we can go out and educate people that may call and they just want to know what is hospice. We can do that. Paul had mentioned that a lot of people think it's only for cancer patients. Our census, usually it's only 40% cancer patients. They have to be at a certain stage. So when we go and do a consult, a physician asks us to go out, that doesn't mean they're automatically going to get on hospice. We go out, assess the patient, and we have to make sure they meet the eligibility. If they do, then we contact the physician, and if the patient wants, we admit. And we do not go in homes and talk about dying. We talk about living each day. Let's make the most of every day. And what can we do for you? So we really get in there. We have to work with families. Everyone goes through these processes different. We're not there to judge. You know, you may have a family of 10 children and you've got a lot of different personalities and levels of grief, levels of coping, and then you also have this patient who's our primary focus, but we treat the family also. And that kind of leads me toward Nicole's going to kind of get up and talk to you about what else we do, you know, after a patient passes.
Question,
Yes,
how
sir.
often do you usually go to the home after somebody's qualified?
Our nurses, we have always made it a standard of practice to visit minimum of twice a week from day one to day end. We never cut down, we never decrease, and we will go every day if necessary.
And then when you're in a crisis mode, it's like waiting on an ambulance. You know, it's like time stops. Having somebody close by makes a big difference. So that's just one thing that one of the major differences. Also, home healths are restricted by how many times they can go. We're unrestricted. We go as needed. You know, we have a
Yeah,
minimum.
Medicare and Medicaid does not state to a hospice how much they can provide. You know, they just allow the hospice to go, and that hospice decides how they're going to care for that patient. We pretty much take care of all their supplies. We cover all the meds related to the illness. If they need nurses' aides for bathing, whatever, how many times a week, they're in control of that. We let them make the decisions. We've got them prepared for what that might happen, what they may see. And we get there, most of the time, we settle the patient or the situation down. If they still insist, they're very panicked, or someone in that family is saying, I want my mom at the hospital, we will allow that and we go with them. And we let that physician check the patient and give his recommendation. If they choose to go back into the hospital and get aggressive treatment, everything that can be done, testing, whatever that may be, then they need to come off of hospice. So Medicare will reimburse the hospital, or Medicaid, or whatever their provider is.
You all are funded by Medicare and Medicaid?
Yes, we are under state reg and federal regs.
Private insurance company also.
Yes.
Most of your private insurances today do cover hospice.
And we'll take indigent patients. I mean, you know, because of the philosophy of our hospice way back when, if someone has no means of payment, we'll still take them. We're not going to leave them out there. And that's kind of the old philosophy from way back when. We've kept that philosophy in hospice. And just like what Rose says, if a patient changes their mind, you know, I always say try it. You have nothing to lose. You've paid all your taxes all your life. Why not take advantage of a service that's extra care? If you try it, you change your mind, it's like turning the light switch off. You turn it off, you're back to where you were the day before. And one thing Rose didn't say, which I didn't know, and a lot of people do not know, if you're in a nursing home and not in the skilled unit, you also can be on hospice too. What a beauty thing to have two different groups looking after mom or dad or your spouse, versus when you're not there, or some people have jobs or cannot be in a nursing home every day checking on their loved one. You have two groups looking after you. You have the nursing home group that's responsible for your patient or for your loved one, and you have the hospice group that's responsible for that patient.
Thank you, Ms. Rose. My name is Nicole DeVille. I'm the social worker with hospice, but I'm also the bereavement coordinator with hospice as well. I'm going to tell you a little bit about what I do as a social worker, and then I'll tell you a little bit about the bereavement services that we provide for hospice too. As a social worker, what my main role is, I do a few different things, but my main role is to be able to provide supportive counseling for our patients, but also for the families as well. Where I'm able to talk to them about encouraging them to be able to communicate to each other. I never push or force anyone to be able to talk with me as a social worker, because some people don't feel that that is something they're comfortable with. So I always try to be able to ensure that the families and the patients are always talking with each other about their feelings. I also be able to help them to be able to reconcile relationships within their families if there have been relationships in the past that have been broken. Sometimes reconciling relationships within their family or some of their wishes to be able to provide peace for them before they do pass. And that is something that I'm able to help them with if that would be something that would be needed for them. I also provide assistance for them with community resources if that is a need for the family. Not all families are the same. Some people have all the resources that they need to be able to take care of someone, and some families don't. I'm able to look into possibly financial resources for them if they're in a crisis, they need some help with the electric bill or anything else in their life that would help them to be able to improve their quality of life. And the bereavement services are not something a family has to do. Some families would like bereavement services and some volunteer not to have any. But those services, what they offer are visits, home visits from me. I can go once or twice a month, whatever the family would like. If a family in the beginning does not like to be able to have home visits, I offer them to be able to stay in phone contact with them. However long within that 13 months a family would like to have that contact. Sometimes, there's good support in the family, and sometimes they can share some things with their family, and sometimes there's things that they can't. So I like to come in to be able to offer that extra support for them. And that goes up until 13 months. We also offer newsletters that I mail out every other month for 13 months. And it's newsletters consisting of information about grief. What are some expectations for the future about what grief is, and what are some things they might be feeling. And the newsletters also talk about different ways of coping with grief and some helpful ways of dealing with that. And I always encourage them to always have contact with us. If there's some times that I haven't called them, or I'm expected to call them next month, but they're going into a crisis or they're having some difficulty, I always encourage them to call me at any time that they need, and we can always make a visit or help them in any kind of other way that I possibly can. And we have a memorial service every year for hospice, which we're in preparation right now of planning that memorial service. We have one every year in November. And it's a night that we invite all of the families of the patients that we took care of. And we have a special night to be able to honor and remember all of them. And
is that from the previous year?
we do it from, right now we're acknowledging all the patients that we took care of from last October until the end of September.
It's not everybody, it's just for the previous.
It's just for one, right. It was very comforting from them to be able to be at the memorial service, especially for some families that they don't know how to be able to outwardly mourn and to be able to show that outwardly remembrance of people. Sometimes in our world there's so many things that we're just ready to get, so busy and get on moving with life, and not to say we forget to remember, but sometimes it's just we don't have time to remember, or it's hard to be able to show that remembrance. So we like to be able to show the families that we remember too, your loved ones that we took care of.